Hello everyone. Continuing the series of solving previous question paper. So in paper 1 of Jan 2025, question number 6 was asked about nerve conduction study. Nerve conduction study procedure. Mainly it's a neurology topic, but at MD level we should know few things regarding this procedure. So we will solve this question now. Coming to the introduction. Here mainly this procedure is done to identify nerve pathologies. So here in this procedure mainly there will be stimulation of a nerve, mainly peripheral nerve. After stimulation they will record the response, then it will be analyzed comparing with normal values, to find out the pathology proper. So this is the thing about nerve conduction study, and here mainly they will do this procedure for both motor NCS and there will be sensory nerve conduction studies. And the preferred nerves will be, it depends on the suspected pathology actually, but commonly in the upper limb it will be done on median nerve, ulnar nerve and radial nerve. Whereas in lower limb usually it will be done on tibial nerve, superficial peroneal nerve and sural nerve. These are some preferred peripheral nerves for the study. So this is the introduction. Coming to the indication proper, when to conduct nerve conduction study. This part you will get to know once I explain about the procedure properly. So we will deal with the contraindications first. So as it is a electrical stimulation of nerves, contraindications can be mainly some implants, defibrillators, even pacemakers. So if the individual is having any of these, usually the procedure will be contraindicated. Now we will discuss how the procedure will be done exactly and how it is analyzed. So here if we consider upper limb as an example, first we will deal with motor nerve conduction study. Okay, here if we consider upper limb and this one as a nerve, so what they will do is, so over the preferred nerve they will place the stimulator. So stimulator which will have anode and cathode poles. Then there will be recording electrodes over the particular muscle. So there will be recording electrodes and one reference electrode will be there. So and one more is neutral electrode. So to label them, this is a stimulator. Here will be the recording electrode. So this is recording electrode and this is reference electrode. So this is the thing. These are placed over the particular muscles to record the response. So once this placement is done, there will be stimulation. So they will stimulate the nerve and they will record the response. So as the stimulus is given, there will be a graph like this. This is called as stimulator artifact. After that, after the stimulation, so stimulus will pass through the nerve. It will cross nerve proper, then neuromuscular junction and the muscle proper. So once it reaches muscle, there will be response. So the response will be usually like this. This will be the response, right? So this is the basic thing. So to here, during analysis and in a graph, what all things we will get. To label this one, for the first wave, we mentioned this as stimulator artifact. Stimulator artifact. So after stimulation, there was conduction and some latency before the response proper. So this is called as latency. Then this is the response. So in the response, mainly we will see the amplitude of the action potential. So this overall area will be considered as amplitude. So this is the amplitude of action potential. Okay. So this is the thing. Now we will understand it in further details. See, the amplitude will depend on the number of axons present. So more the number of axons, response will be better. And this latency and conduction speed will depend on the myelination of the nerve. So if there is good myelination, the latency will be shorter and conduction speed will be good. If there is demyelination, we can expect blocks and latency will be prolonged. So this is the basic concept. So to simplify them, amplitude is equal to axons and latency and velocity. Here, this flat line is utilized to measure both latency and velocity. So these things will imply mainly about the myelination. So this is the basic idea. Now, what happens is, if we consider this as a median nerve stimulation, so once median nerve is stimulated, the preferred muscle will be abductor pollicis brevis. So this is the preferred muscle in which the response will be recorded. And during analysis, for all of these measures, amplitude, latency, even velocity, there will be some normal values. So once we get the report of this particular individual, we will compare with the normal values to find out the pathology proper. Now we got that it is easier to get amplitude. It will be usually in millivolts, and latency. But what about the velocity? Like how fast or how slow is the speed of conduction in the nerve proper? Here we know that after giving stimulus, the stimulus is passing through nerve, neuromuscular junction, and then muscle. So these many components are involved. But we want the speed of conduction only in the nerve. We are not bothered about speed at neuromuscular junction and muscle. So for this, what we will do is, we will give one more stimulus. See here, if we consider this as elbow, forearm, so first stimulus was given at the proximal site. Second one will be given at a distance. So this will be distant stimulator. And same, after stimulus, they will record the response again. So again, this will be a similar curve like this. Here what happens is, when we give stimulation at distal point, the latency will be little bit short. Okay. So if we consider this latency as, for example, some 4 seconds, just for an example I am saying. So after giving stimulus, till we get the response curve, it was a 4 seconds latency. Whereas when we gave stimulus at proximal point near the elbow, this after giving stimulus to get the response, it was some 10 seconds, for example. Okay, it was the latency. Now based on this one, we can calculate the conduction velocity. So we all know that formula for velocity is equal to distance by time. Okay. So here distance will be, so we want to calculate the velocity in this particular nerve. We don't want neuromuscular junction and muscle part. So what we'll do is, for distance, we will see the gap between proximal and distal stimulators. Usually in ideal scenario, it will be 10 centimeters. Okay. And coming to the time, so here we will see the latency gap between both the points. So here it will be 6 seconds. So this will be the velocity. So if we divide, we will get the velocity. And this will be measured usually in meter per second units. And as I mentioned, for every analysis, there will be some normal values. Usually in upper limbs, normal speed will be 45 to 50 meters per second. And if the values are less than 35 or something like that, less than 30, it indicates slow velocity. It is nothing but demyelinating disorder. demyelinating disease. So this is the importance. And here one more point is this amplitude, whatever we have told, is called as CMAP. So this is called as CMAP, compound muscle action potential. Compound muscle action potential. Why is it called as compound? Because this action potential is the result of both involvement of nerve as well as muscle. That's why it is called as compound motor action potential. So this is the thing. Then coming to the sensory nerve conduction study, the parameters recorded will be same: amplitude, velocity, and the latency. All these things will remain the same. Only terminology will differ is in amplitude it is called as SNAP, sensory nerve action potential. Sensory nerve action potential. So we will see the procedure because it will differ little bit. So I will just wipe it out. So coming to sensory nerve conduction study. Again, to draw that schematic diagram, so here what happens is, we know that the conduction direction will be reverse here. Okay. So suppose if we are considering again the median nerve, here what happens is the sensation will be carried from distal to spinal cord. This is the normal path. So here two types of studies can be done. One is called as orthodromic. One more is called as antidromic. So to understand these terminologies, if the stimulator is placed here, and if the recording electrodes, and this is recording and this is considered as reference electrode, if they are placed distally, and the stimulus is given from here and the response is recorded here, so it will be in this direction, which is the normal direction of sensory flow. So this is called as orthodromic. Suppose we reverse it. For example, if we are considering stimulus here, and we are measuring the response distally. Suppose we place electrodes like this. Usually these will be ring electrodes in the ring form. So response, like recording electrode and reference electrode, are placed here. So this will be opposite to the direction of flow. That's why it is called as antidromic. Only the direction will decide these terminologies. So after this, everything will remain same. After stimulus, they will record the response and we will decide those same parameters. For example, amplitude, latency, and velocity. Based on these things, amplitude will decide the axonal pathology, and velocity and latency usually will decide demyelinating pathology. That remains the same. And one more study which can be done during nerve conduction procedure is repetitive nerve stimulation study. So repetitive nerve stimulation study. Here what they will do is, same at the stimulus point, they will give a train of stimulation. For example, like some up to 10 stimulus will be given, and they will start recording the response. So normally for each of the 10 times, the measured parameters should be same. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right. So the response should be same in amplitude mainly. Suppose after some third or fourth stimulus, suppose the response falls. For example, first stimulus led to this much of the response, second one, but third one was like this, fourth one was like this, fifth, sixth, again at the end it recovered, for example. So at third or fourth train of stimulus, if the response falls by more than 10%, it is significant. Why is it significant? It is suggestive of myasthenia gravis, and usually the overall response graph is called as U-shaped detrimental response. a typical feature of nerve conduction study in myasthenia gravis patients. And you know that in some cases, as the stimulus train will go on, the response will be more. For example, first one, second one, third one, like the response will increase in the intensity. So this is seen in case of Eaton-Lambert type of myasthenic patients, Eaton-Lambert syndrome. So this is about repetitive nerve stimulation study, mainly for NMJ disorders. Okay. So this is the brief explanation about the procedure. I told in the beginning that once you get to know the procedure, you yourself will write the indication for the nerve conduction study. So to list out the indications now, so the indications are mainly to decide the type of pathology. For example, axonal versus demyelinating disorder. Demyelination. Then to localize site of lesion. For example, whether it is proximal or distal. Third one is to find out structure responsible for symptoms. For example, whether it is peripheral nerve or neuromuscular junction or even muscle disorders like that, or even anterior horn cell. So these are some indications to do nerve conduction study. And finally, a small note on F wave latency. So in the nerve conduction study, we saw that we will give a stimulus and distally somewhere we will record the response. So here we will give the stimulus, right? So the stimulus is traveling in this direction, and meanwhile we have to remember that stimulus will also travel in the other direction. So it will travel till the spinal cord, and at anterior horn cell there will be that H reflex. So in response, again you can see the response by the same muscle. So what happens exactly is, we give the stimulus, right? So this is stimulus artifact. After latency, we got a response of the muscle. But we are saying that meanwhile the stimulus is traveling in other direction, reaching spinal cord, and from anterior horn cell we are getting the second response. So after some time there will be one more wave like this. So this is called as F wave. So normally there will be some gap between the main response and this F wave. So based on this, if it is getting prolonged, it will tell many pathologies, like if there is any conduction blockage or pathology with the anterior horn cell, like that. Again, helps in finding out conduction blocks or conduction abnormalities. So this is about F wave latency related to H reflex. I hope this was ideal for MD level to understand, because many a times when we get neurology case in our wards also, we require nerve conduction study. But the thing is, we will not be able to read the report. So at least this basic idea will help in reading the report of nerve conduction study. Hope you got the point. See you in next video. Thank you so much.